Hi, I'm Samantha Zwiebel. Thank you for joining me. I'm going to be talking about and introducing A Tale of Two Ketamine's clinical innovation and controversy at the intersection of mood and substance use disorders for ACLP 2025. We've been told that this talk is not going to be for CME, so just be mindful of that as you're watching the presentation. I have no disclosures. I do occasionally get speaker honoraria from eligible organizations. Our learning objectives: we hope that you'll be able to compare some of the FDA-approved indications of ketamine as well as some of the off-label uses, describe the pharmacology of ketamine that lends itself to this variety of conditions, and analyze established and emerging uses of ketamine relevant to you as a CL psychiatrist, as well as assess some of the potential risks of these different indications and using ketamine in all these ways. So, a tale of 2 or 3 or 4 or 8 ketamines. We have all different speakers in our panel, and we use ketamine in very different ways in very different patient populations. And so when you hear ketamine, what is it that you're thinking of? Maybe you're thinking of depression treatment. Maybe you think of these ketamine clinics that are popping up, marketing it as, good for just about anything psychiatric. Maybe you think of pain management adjunct, high opioid tolerance patients. Maybe you think of substance use and overdose. Maybe you think of agitation management. So what are you supposed to do in what you might call the minefield of innovation and how we're using ketamine these days? You should be educated about off-label use because this is a clinical reality. Ask yourself, does this make sense to use ketamine in this way? What is the evidence? What are people actually doing clinically so that you can form your own opinions? To that end, I'm going to start with ketamine for patients with opioid use disorders, which is how I use ketamine. I live in Philadelphia, and we have lots of fentanyl, no heroin left. It's been like that for years. So we have lots of challenges treating opioid use disorder always, and especially in 2025. So fentanyl is extremely potent, and people are using a lot of it. Fentanyl has now become more prevalent than heroin even. And when people say that they're using heroin or fentanyl, what they're really using is sort of this admixture that we also colloquially refer to as dope, which contains other synthetic opioids that are highly potent. And people who are using fentanyl end up developing this extremely high opioid tolerance that clinically just seems almost unbelievable. And what this translates to is that treating acute pain in patients who use fentanyl when they're hospitalized can feel super daunting, overwhelming. Maybe you feel helpless, hopeless. Sometimes it almost feels impossible. So as I was saying, fentanyl has become highly prevalent and is more common than heroin now in this country. And a recent study found that among folks using opioids that were non-prescription, that might be actually like 11% of respondents of this survey. So it's really quite common. Fentanyl is very dangerous. It is what has been driving the overdose epidemic. You actually see that heroin deaths are going down. Fentanyl is kind of an oddball pharmacologically because it's got a pretty similar half-life to other opioids, yet it's so much more potent. So it's in that like 3 to 7 hour half-life, and because it is highly lipophilic, that is what translates to it sort of looking a lot more potent than some other things like morphine or heroin. And that's because it's really fast onset because of how lipophilic it is as it's crossing all of these membranes. And then it can bind to the mu-opioid receptor, possibly in like 3 different conformations. So that's also important. It can come from the top as well as the side, all related to how lipophilic it is. Part of this is that it may actually end up accumulating in adipose tissue. We see that despite this really short half-life, that fentanyl as well as norfentanyl have this really protracted withdrawal and take a long time to clear. So patients get this really high opioid tolerance and end up using the equivalent of thousands of MMEs a day. And what this leads to is intolerable pain and withdrawal for patients when they come into the hospital. And it's difficult when they do come into the hospital because there's a lot of stigma and fear and false assumptions about this patient population. And many providers are unfamiliar about how to give opioids for opioid use disorder properly because the dosing is so different than what we normally do. This leads to people being frequently underdosed, and they can feel worse in the hospital than they do out in the community. Now, some people are going to attempt to compensate for this high opioid tolerance by giving potentially thousands of milligrams of oxycodone, really high dose hydromorphone PCAs. But sometimes it's not quite good enough. And even this, because of the opioid tolerance and how it works may not end up being enough. And we're seeing this, what I call the second epidemic of self-directed discharges and incomplete medical care for these patients, which is a huge equity issue. And then even if you are trying to give lots of opioids, you're giving lots of opioids. The DEA might notice and come talk to your hospital about this, whether or not you feel it's clinically appropriate. What are some of the strategies that people have already tried? Well, give more opioids, but it's really a lot of opioids that you would need to give somebody in order to catch up for the amount that they're using outside of the hospital. We all try comfort meds. We all know that they're not very comforting. Maybe you get a pain management consult, but they're not necessarily familiar or comfortable with the dosing that's necessary to meet the requirement of this patient population. Maybe you have an addiction medicine consult team that's available to you. Maybe you don't. Even if you do, it's possible that they are going to have the same struggles that you do because you're working with the same toolbox. So this might be a really typical case that you see where you've got a middle-aged person coming in. Maybe they had a remote history of a surgery, were given opioids, developed a dependence that turned into an addiction, prescribed oxycodone turned into street oxycodone, turned into heroin, turned into fentanyl. And now she's admitted to the hospital with a spinal abscess, bacteremia, had a washout, all these really, really painful spinal surgeries. And you are consulted to take care of her. And when you go see her, she is absolutely miserable. So what are you going to do for her? So I asked a very, very distinguished colleague, what would you do? And I was told, they simply can't be treated. They will always have pain, and they will stop breathing before you have pain control from opioids. And it turns out that might actually be true, but it sure shouldn't stop you from giving up. And what you see in this graph is what we call differential tolerance. And what this means is that on the left, you can see that as people get higher and higher doses of morphine, they develop tolerance to the analgesic effects. However, on the other side, you can see that there's almost no change in the respiratory depression. So you actually are not developing tolerance to opioids in that regard. And what this means is that somebody can effectively overdose on an opioid before they have pain control. However, telling your patient that because they use fentanyl means that they don't get pain control is unacceptable, in my opinion. And so if your best isn't good enough, just means you got to get better, right? And your patient needs you, and you are now looking for some sort of miraculous hero drug that is going to fix all of this. And this sort of medication would somehow address the opioid tolerance so that you could give opioids again and they'd be more effective. It would help with pain control, withdrawal, preferentially not have many side effects. It would work quickly, have multiple routes of administration. The dosing would be super easy. Patients and providers alike would be cool with it. And it would be inexpensive and never on shortage. Well, we call that ketamine. Ketamine is already used to treat pain, and it pharmacologically makes so much sense. So in this diagram here, you have your yellow presynaptic, blue postsynaptic, and your presynaptic neuron releasing the purple glutamate, and it's going to attach to your glutamatergic NMDA receptor to transmit some of the pain signaling. And what ketamine does is that it's an NMDA antagonist, and it's actually going to sit in that channel and block it so that you are no longer transmitting the pain signal. It literally sits in there and blocks it. It also inhibits uptake of dopamine, serotonin, and ketamine even has some new opioid receptor agonism. So talking about nociception, hyperalgesia, and central sensitization in this patient population, we know that exposure to a lot of opioids like fentanyl is going to cause opioid-induced hyperalgesia. And here on the left, we have a diagram, again, the yellow presynaptic, blue postsynaptic, we've got our green NMDA receptors. And what happens in central sensitization is that the NMDA receptors become phosphorylated, and that means that magnesium is no longer blocking the NMDA receptor, which was necessary for it to not constantly be activated. And so when you no longer have that, NMDA receptors remain open and a lot more active, and they are constantly transmitting pain signals. However, we know in theory and in practice that you can give NMDA antagonists to help with this, such as ketamine. So we already know analgesic dosing of ketamine. I've got it here, which is different from sedation. and agitation management, which is different from when people are totally dissociated, as well as depression treatment, which I don't have on this slide. So pain dosing should not cause dissociation or hallucinations. It's quite low. Can it happen? Maybe. But it's really, really low, and it's so low you don't even need to taper most of the time. So back to our patient. Our team worked with our outstanding hospital pharmacist, made a small increase in the oxycodone dose that really shouldn't have made too much of a difference, and added some weight-based oral ketamine. Within 5 days, no other medication changes. She looked so much better and was doing really, really well. So we've taken this idea and are trying to make it more popular out in the world. Our pharmacy group has published on this, has another paper in the process. We clinically published this in JACLP. Our hospital has protocolized it so that it's a normal recommendation to consider ketamine for patients with OUD who are using fentanyl. We've also operationalized it into our electronic medical record so that you can just click weight-based dosing of oral ketamine. Makes it nice and easy. And this approach has been socialized in Philadelphia, again, where we have very high prevalence of fentanyl for people with opioid use disorder, and we are by no means the only hospital in Philadelphia doing this. There's also been a recent scoping review about ketamine for opioid use disorder and opioid withdrawal. And I wanted to point out again that there's like really old literature on using ketamine for this. We're by no means the first people to think of this. You can find plenty of case reports, case series about using ketamine in this way. And even now, because during surgeries, people can get very fast onset opioid-induced hyperalgesia, or like opioid tolerance develops very quickly. You'll notice that intraoperatively, people do often get ketamine. It's not necessarily for the sedation. It helps with the opioid so that it maintains its efficacy throughout the surgery. In this review, however, most of the newer literature is focusing on ketamine as an actual treatment for opioid use disorder, as well as for precipitated withdrawal from buprenorphine. And at the time this was published, it seems like our group may be the only folks who have published on how we use ketamine. But again, we're not the only people out there doing this. Some of the limitations of using ketamine, I will say, ever so often you get someone who does really like the ketamine. It does have addiction potential. That being said, we rarely actually end up having this issue for the frequency with which we use it and for the population that we're using it in. Ketamine itself carries a lot of stigma and bias, and a lot of providers may object to the idea of giving a drug that does have addiction potential to someone who already has an addiction. One limitation of ketamine is the availability based on the formulation and your ability to use it, basically. So at my hospital and other Penn hospitals, we have oral ketamine, which is available for use on the floor. We take the IV solution of ketamine and we simply dilute it and then add it to beverages so it doesn't taste quite so nasty. And people drink the IV solution. Maybe you have troches. These are quite rare, however. So most hospitals are not going to have oral ketamine. And if you do have ketamine, it's probably IV, and you're only going to be able to use that in an intensive care unit. Another consideration is that often in withdrawal, you'll see a sympathetic surge with tachycardia, hypertension. Ketamine can also cause these issues, and so you want to be really careful in how you use it, especially if you've got somebody in severe polysubstance withdrawal, such as a medetomidine withdrawal. So back to our patient. So after using the ketamine, again, just 5 days, at the end, within 2 weeks of all of these super painful spinal surgeries, she was off all full agonist opioids, and she was happy about it. We had her on a full therapeutic dose of buprenorphine, no ketamine, and we didn't have to negotiate at all. And oftentimes when people are in pain on opioids and the team's trying to taper, regardless of whether or not they have a use disorder, there is bargaining and negotiation, and it's really difficult. And instead, everything went super well, and she was just discharged to a facility with connection to aftercare for the buprenorphine. So the key points of this talk are that in the fentanyl era, things are more difficult. You need to innovate. Patients have really high opioid tolerance, which leads to inadequate pain and withdrawal control, people leaving before they have finished their medical treatment and bad outcomes, and this is really an equity issue. NMDA receptors are what I would call hyperactivated in states of central sensitization, which makes it a pharmacologic target for how to undo that. And that means that if you give an NMDA antagonist, you can effectively reset somebody's opioid receptors, is what we explain to patients, and it helps with opioid tolerance and opioid-induced hyperalgesia to treat pain. And ketamine used in this way is actually not that innovative. It's pretty old school, but I do think that we could afford to be more mindful of it. And I just want to say thank you and turn it over to our next speaker.
Hello, my name is Shamim Nejad. I'm the Medical Director for Addiction Medicine Consultation Services and the Psychiatry Consultation Services at UW-Medicine Valley Medical Center. Big thank you to my colleagues, Dr. Zwiebel, Dr. Hamm, and Dr. Zabinski for their kind invitation to include me on this particular topic. My section for this talk is going to be centered around the use of ketamine in the setting of buprenorphine induction, and I'll more specifically present data, including a case series of our patients to date this year, utilizing our hospital's MOUD pathways, ketamine-assisted buprenorphine induction protocol. And you may hear me utilize the term CABI as an abbreviation for this. I have no conflicts to report. As an overview, I'll briefly go over some general aspects of the opiate and fentanyl epidemic, and particularly as it relates to the increasing complexity of buprenorphine induction, including the risk for severe precipitated opioid withdrawal, which has really caused us to rethink our approach and clinical management for patient care. In addition, I'll also present the framework for the hospital's MOUD pathway, which has both methadone and buprenorphine as MOUD options, including different potential strategies which clinicians can consider for buprenorphine starts. However, our main focus for this particular talk will, of course, be on ketamine-assisted buprenorphine inductions, including a review of the case series of patients we've been able to accrue since the beginning of January 2025 until September of this year, shortly before this year's conference. As everyone knows, we've been in the midst of an opioid epidemic, which has steadily worsened for approximately the last 10 years, including the replacement of heroin in the drug supply with fentanyl. However, as you can also see from the graph, we see a significant rise in methamphetamine use and to a lesser extent cocaine use in this same time period. For most patients, these are not exclusive, but rather concomitant use, and again, raising the complexity of trying to optimize care for patients and to assist them in getting into recovery. One of the most clear and unfortunate things with regards to fentanyl taking over heroin in the drug supply is this increased incidence of unintentional overdose deaths. Clearly, for our particular region here in the Pacific Northwest, this continues to be the case. However, when we look in more detail to the regional characteristics for substance use, and in this case for the larger Seattle area, there are several things which may be unique and quite different when compared to other regions of the country. As you can see from the data, more than 50% of the confirmed overdose deaths involve the use of methamphetamine. In addition, over the last few years, we've seen fentanyl powder to be the main form of fentanyl that patients are using, and the vast majority smoking their supply with very little IV use, and thus very quick CNS penetration. And lastly, the pharmacokinetic properties of fentanyl, including its lipophilicity, has made buprenorphine initiation much more complicated due to the risk of precipitated withdrawal, even days after the last use of fentanyl. I think as consultation psychiatrists, it becomes very clear that with the concomitant use of other substances, the presence of various adulterants found in the drug supply, coupled with the pharmacokinetic and pharmacodynamic properties of fentanyl, that MOUD inductions are actually more than just the mu opioid receptor. Certainly it's a major component, but given the various regional differences in drug use and adulterants, MOUD protocols likely need to be dynamic in their management and have the potential for utilization of adjunctive medications to help ensure symptomatic coverage outside of the mu opioid receptor. That will certainly give our patients the best chance of getting into recovery. To be able to provide as much of a dynamic approach for clinical care, our hospital has created a formalized hospital-based MOUD pathway, with a default pathway at the time of admission to the hospital being management with methadone. Given the high frequency of traumatic injury, acute pain, and need for wound care, methadone can help stabilize patients quickly. And just to emphasize, there is no such thing as an emergent new buprenorphine induction. Upon eventual stabilization, however, and in particular when patients can engage in more meaningful discussions with regards to OUD management, and again, as a reminder, the majority of our patients in this region have severe methamphetamine use and often not in a position cognitively or neurobehaviorally to have these discussions when they're first admitted. So when the patients are then stable, we can then provide them all options with regards to MOUD management, which they may be interested in. And for those patients who may be interested in switching to buprenorphine for MOUD management, the protocol has options for rapid low-dose induction, which data is actually being pulled for publication at this time as well, low-dose induction strategies, and of course, ketamine buprenorphine induction, which is what we'll focus on. So why ketamine? Ketamine as a medication is nothing new. Has been utilized clinically for many years. This includes for pain management, including for acute pain, particularly in those patients who often have a history of chronic opioid therapy and or OUD, resulting in high opioid tolerance, for chronic pain management and in patients with opioid-induced hyperalgesia. More recently, we've seen case reports for the use of ketamine for opioid withdrawal, in addition to a recent case series from some of my colleagues here in Washington State for the use of ketamine in the ambulatory setting to help manage underlying withdrawal symptoms during buprenorphine induction. At our institution, the use of sub-anesthetic ketamine has been utilized on both medical and surgical floors to assist with pain management, particularly in those patients with high opioid tolerance, requiring high doses of opioids for symptomatic control. Because of this, there's been an existing comfort level and natural transition to utilize ketamine for anticipated complicated buprenorphine inductions. So just to clarify, sub-anesthetic doses of ketamine are generally regarded as doses less than 0.3 mg per kg as a bolus and 0.1 to 0.2 mg per kg per hour as a continuous infusion. Multiple studies on sub-anesthetic dosing ketamine has demonstrated that there are no measurable cardiovascular effects. In addition, ketamine, again, at sub-anesthetic doses, does not appear to have any significant effect on the respiratory system. The use of ketamine in patients with TBI has been cautiously viewed in the past, largely due to its possible deleterious effect on cerebral circulation and perfusion, with early studies suggesting that ketamine may increase intracranial pressure, decreasing cerebral perfusion pressure, and thereby reducing oxygen supply. However, recent studies have refuted these conclusions relating to the role of ketamine, especially in patients with TBI, and in the recent studies have actually been associated with ICP reductions. Certainly for sub-anesthetic dosing of ketamine, the clinical risk for increases in ICP seems to be negligible, if even an issue at all. My colleagues will be discussing the pharmacology of ketamine in more detail. However, just briefly, ketamine is highly lipid soluble with a large volume of distribution, metabolized primarily via 3A4 pathway with an elimination of 3 to 4 hours and a distribution half-life of about 15 minutes. Ketamine's mechanism of action is regarded as one of pharmacology's most complex due to its interactions with multiple binding sites, including NMDA receptors, opioid receptors, sodium channels, and L-type calcium channels. The primary effects of ketamine is associated with the NMDA receptor blockade. However, ketamine also exhibits high affinity for the dopamine D2 and serotonin 5-HT binding sites and significantly inhibits their uptake. Ketamine has also been shown to bind to all types of opioid receptors, with the highest affinity being for the mu receptors, then kappa, followed by delta receptors. However, it should be mentioned that ketamine's interactions with opioid receptors are not believed to produce a significant analgesic effect. For example, ketamine's analgesia is not reversed by administration of mu-opioid receptor antagonists, such as naloxone, which suggests that at least mu receptor binding plays minimal, if any, role in ketamine analgesia. Again, turning our attention to the case series involving the CABI pathway. Retrospectively, we examined patients with OUD who underwent buprenorphine induction at a 341-bed public district hospital serving the South King County area, utilizing the hospital's MOUD pathway CABI induction protocol during hospital admission from January of 2025 through September of 2025. All patients were seen by the Addiction Consultation Service, which includes an addiction medicine physician, social worker, in addition to an MOUD navigator to assist in linkages to care upon transition out of the hospital. Eligible patients were adults greater than 18 years of age who wished to pursue MOUD management with buprenorphine during their hospitalization between January 2025 through September 2025 with the Addiction Consultation Service. The Addiction Consultation Service maintained a record of patients who underwent CABI, including verification that patients underwent ketamine-assisted induction via review of the electronic medical record. Once patients were stabilized medically and with acute MOUD management, the patients were then engaged with regards to their interest in longer-term MOUD care, including either continuation of methadone versus transition to buprenorphine. If patients were interested in buprenorphine, including the utilization of CABI, they were provided details regarding the induction process, including the utilization of adjunctive medications. They were also instructed to be proactive in utilizing PRN medications should they need it during the induction process. Furthermore, patients were also instructed and asked to avoid using fentanyl or other substances during the induction process while in-house, especially as it may increase their risk of side effects, including severe precipitated withdrawal. A round of CABI included administration of 0.5 milligrams of oral lorazepam, followed in 15 minutes by ketamine 0.2 mg per kg IV, followed in 15 minutes by buprenorphine 8 milligrams sublingual formulation. A second round was followed in approximately 4 hours, following which the patient was started on buprenorphine 8 milligrams 3 times a day, roughly 4 hours after that. Thus, patients on the protocol would typically receive 24 milligrams of buprenorphine in roughly a 12-hour period. Patients all had usual PRN medications available for symptomatic management of opioid withdrawal, including low-dose oral lorazepam, dicyclomine, methylcarbamol, ondansetron, loperamide, in addition to extra doses of ketamine, 0.1 to 0.2 mg per kg IV, Q6 hours, PRN cow score 8 or greater. Lastly, patients could also be placed on standing methylcarbamol, dicyclomine, clonidine via utilization of a patch based on clinician preference. If patients were on methadone, this was discontinued roughly 8 to 12 hours prior to initiation of CABI. However, short-acting PRN full agonist opioids utilized for pain were continued if they were ongoing clinical need for their use, and their use was not a contraindication for induction. Researchers reviewed all orders to confirm CABI initiation, along with verification of adjunctive PRN medications. This included administration of methadone and PRN short-acting opioids for pain management, if they were administered. Discharge orders were also reviewed, including verification of discharge prescriptions from the hospital pharmacy. Primary outcome was successful completion of CABI, which was defined as the patient having received a total dose of 24 milligrams within the first 24 hours of the induction process, and verification of successful induction as documented in the electronic medical record. Secondary outcomes included discharge with prescriptions for maintenance buprenorphine management, along with nursing-assessed clinical opioid withdrawal scale scores, or COW scores, during the induction process to assess the effect on withdrawal symptoms, including the risk for buprenorphine-precipitated opioid withdrawal. This was defined as a COWS increase of 5 or more from baseline COW score, which was done at the initiation of induction, roughly 2 hours or less from the time of buprenorphine dosing. Patient characteristic data is presented, and a few things to highlight. One is the majority of patients who underwent CABI were actively using fentanyl at the time of hospital admission, with 50% also using methamphetamine as well. Something important to also note is that 16 out of 25 patients were actively receiving full agonist opioids in the 24 hours prior to CABI, with an average oral morphine equivalent of 131 milligrams. In addition, 15 out of 25 patients received methadone for MOUD management in the 24 hours prior to CABI, with an average methadone dose of 54 milligrams. And as previously mentioned, for those patients with clinical need for ongoing use of short-acting full agonist opioids for pain, 18 out of the 25 patients continued to receive PRM medications either during or following CABI. Each patient's medical and surgical conditions are also presented, coupled with the patient characteristics for further comparison. This also includes two cases of patients who were admitted following cardiac arrest in the setting of being on methadone maintenance, necessitating transition to buprenorphine for longer-term MOUD management. Each patient case is presented with COWS scoring data, including COWS score at the time of induction designated as day 0, with the first day, or roughly the first 24 hours of induction, labeled as day 1. As you can see from the data, the average COWS score at the time of CABI was initiated was 2, indicating that no significant acute withdrawal symptoms were present at the time of induction. Only 4 patients demonstrated an increased change in COWS scoring of greater than 5, raising concern for buprenorphine-precipitated opioid withdrawal. When reviewing these cases, all 4 cases were associated with in-house use of fentanyl, which likely contributed to the observed side effects. In-house fentanyl use was verified by either patients notifying the team due to symptoms being experienced or being found with substance use paraphernalia by staff. Upon discovery of this, patients were then asked about ongoing unmet needs, their interest in ongoing CABI, including increased utilization of adjunctive medications versus transition back to methadone. All 4 patients were agreeable to continuation of CABI with the utilization of adjunctive medications. All 25 patients completed CABI, and all 25 patients received buprenorphine prescriptions from the pharmacy at the time of discharge from the hospital. For those patients who seem to be motivated for buprenorphine induction, the utilization of a ketamine-assisted buprenorphine induction utilizing sub-anesthetic dosing seems to be a safe option and with beneficial clinical outcomes. And a few things to highlight regarding the protocol in the case series. The CABI protocol utilized was simple enough for staff and nursing to follow and should easily be translatable and reproducible. I think one of the hard components is modernizing and updating ketamine policies at hospitals so that they can be used on medical and surgical floors and not be restricted to the CCU settings. Prophylactic use of ketamine seems to also be associated with decreased risk of buprenorphine-precipitated opioid withdrawal, and thus there's really no need to wait for patients to withdraw and feel physically sick before initiating treatment. And importantly, there's an ability to get to full maintenance buprenorphine dosing in less than 24 hours, despite patients having received significant doses of full agonist opioids in the 24 hours prior to induction. Furthermore, it seems to allow for buprenorphine induction even when patients are receiving full agonist opioids for pain management, which clinically is important for many of our patients with ongoing longer-term wound care management needs and other acute pain symptoms which they may be experiencing. At our institution, sub-anesthetic ketamine has transformed buprenorphine induction practice for general hospital patients, and we hope to be able to further fine-tune dosing and the frequency to continue to improve outcomes, along with optimizing patient comfort during buprenorphine induction processes. Thank you again for having me, and if anybody has any questions, please feel free to email me at any time, and I'll try to get back to you as soon as I can. Thank you.
I'm Brandon Hamm at Northwestern University, and I started our ketamine clinic about 2 years ago. Today I'm going to talk about a subject that has been of interest to me this last 2 years, and this is candidacy for ketamine infusions for treatment-resistant depression in patients with comorbid substance use disorders. I don't have any disclosures. So briefly, I'll touch on the use of ketamine for depression, treatment-resistant depression, and suicidal ideation. There have been many studies on this here. This is a randomized controlled trial. It was published in 2019 in AJP for treatment-resistant depression using 0.5 milligrams per kilogram of IV ketamine for infusion. over 40 minutes, and then a control arm of midazolam. And so in this study, you see in the top part of the figure that the responders separated from the non-responders, with non-responders looking similar to the control arm, but responders having a significant, a major decrease in their depression MADRS score within 24 hours. And then in the bottom part of this figure, you see that the treatment responders over the course of 6 induction doses, it's typically 6 induction doses and then maintenance treatment after that. Over the 6 doses, they were able to get a significant drop in their MADRS scores, with the most common session for capturing a antidepressant response being the 3rd infusion, which lines up with what we see in clinical practice. Then we've got the suicidal ideation aspect, and so the MADRS has a item for suicidal ideation and a range of 0 to 4 points, and so here you see the suicidal ideation scores drop down for treatment responders and maintain down to very low score. So now let's shift to thinking about when we're trying to get those effects for patients, but they've got a comorbid substance use disorder. How can we think about their candidacy for this treatment in that setting? So first, I'd like to think about, is the substance use disorder going to diminish the ability for ketamine to do what we need to do for antidepressant effect? Then also thinking about, is it going to make it any less safe for this patient to have the comorbid substance use disorder and to get their ketamine infusions? Will the ketamine make the addiction worse or better? And general sizing up the substance use disorder, which I'll talk on a little bit more in future slides. I think it's very important to consider the impact of the substance use disorder on the efficacy of ketamine for depression treatment. So first, looking at GABAergic substances, and here the substance that's studied is actually just benzodiazepines, but alcohol and barbiturates, reasonable to consider extrapolating to the mechanism of action of ketamine for depression treatment response. The major theory is disinhibition of glutamatergic pyramidal neurons and accomplishing this glutamatergic surge via inhibition of GABAergic neurons. And so GABAergic stimulation with GABAergic substances would be counter to that. Well, it is the case that though it's mixed data, if you look at all studies together, there's a signal with several studies that benzodiazepines do attenuate the antidepressant response of ketamine. In one study looking at just a diazepam 8 milligram equivalents or more a day worsened outcomes. Then you have naltrexone, which also has some studies that didn't replicate the impact, but several studies demonstrating naltrexone 50 decreasing efficacy of ketamine for antidepressant response. And then actually this last year, we have this functional MR SPECT study that is showing an attenuated glutamatergic surge during ketamine infusions with naltrexone. Here I list tobacco because tobacco smoke does induce some cytochrome P450s, including ones that are relevant for ketamine metabolism. Does it have an impact on efficacy? It's not really been studied, but it's a reasonable consideration. And then there's also substance-induced mood disorder. In those kind of scenarios, it's maybe not the antidepressant choice that's as pivotal, but rather the sobriety intervention that would be relevant for de-escalating depression. And so maybe that would decrease the likelihood of ketamine for as being having antidepressant efficacy if really what you need is a solid chemical dependency intervention. Next, let's look at the impact of a substance use disorder on the safety of just the ketamine infusions. So tachycardia and hypertension are things we look out for in ketamine infusions, and there are a variety of substances, for example, nicotine stimulants, PCP, that if one were intoxicated with, they could have increased propensity for tachycardia or hypertension. The flip side would be withdrawal syndromes from some other substances, including benzodiazepines, alcohol, could also cause these changes. And then we've got oversedation would be another risk if intoxicated on sedative substances, opiates, benzos, alcohol. This could also synergize sedation from ketamine and potentially increase safety concerns. Confusion and agitation with intoxication or withdrawal syndromes would also be some areas where safety could be impacted. So this is a very important area for this section. Is the ketamine treatment expected to worsen or improve the substance use disorder? First, we're going to look at alcohol, which has had several randomized controlled trials. And actually, we've got randomized controlled trials demonstrating increased abstinence for patients that are receiving IV ketamine infusions. Interestingly, there's a randomized controlled trial comparing IM naltrexone to IV ketamine infusions, and it had similar decrease in readmission rates compared to placebo. Speaking of naltrexone, if naltrexone is essential for patients' alcohol use disorder sobriety, then that's a bit of a conflict because naltrexone can attenuate the ability for ketamine to have an antidepressant effect. Cocaine also has had several randomized controlled trials for cocaine use disorder or stimulant use disorder with cocaine, and decreased cravings, reduced use, and one study demonstrating clear increase in abstinence and decreased relapse. Next, we're going to look at opioids and cannabis. Opioids also with some randomized controlled trials. Increased abstinence in these two randomized controlled trials thus far. And then there was a little case series just published this last month, looking at patients with depression, initiated on methadone, and doing ketamine infusions alongside it, and they were all abstinent 3 months. It's just three patients in that case series. But here again, if the patient needs naltrexone for their sobriety, then that can be a conflict with the ability for ketamine to do an antidepressant response. Cannabis, much less studied. I've only come across this one case series. There's 8 patients. They received ketamine infusions, and they recorded decrease in cannabis days per week in that case series. Less clear to me if there would be any impact, positive or negative, on tobacco use disorder based on current studies. And then this also hasn't been studied, but theoretically, I think probably worsening of, ketamine abuse. But PCP abuse, a couple reasons why would be cross-sensitization, and then the altered sensorium changes potentially triggering craving for PCP or inducing a relapse state. And then regular psychedelic abuse, one could argue that a patient could be reinforcing a trip chasing behavior, and that could influence relapse to do ketamine infusions. I'll not spend too much time here, but doing a thorough substance use disorder evaluation is important for patients in ketamine candidacy. What substances, how long, how much, are they switching from one addiction to the other? Is this active? How severe? What do I think their prognosis for sobriety is based on their stage of change and their adherence and sobriety run history? Though it may seem like a ketamine clinician's role is a bit circumscribed, there's no rule that says that The ketamine clinician can't be involved in substance use disorder monitoring and treatment, especially in collaboration with the rest of the treatment team, outpatient psychiatrists or addiction specialists. And this actually can be a window of opportunity and almost like a tool within motivational interviewing for a patient to move them along, gain some motivation for actually following through with some chemical dependency interventions. On the monitoring end, you've got the urine drug screens, the immunoassay, give you some quick data in the days prior to a infusion, whereas the chromatography mass spec give you some more comprehensive data. It's not going to be there a couple days later, at least in my system it wouldn't. However, it's more comprehensive data, and this can give the patient some accountability as well as reassurance that we're taking their addiction care seriously. And you've got a breathalyzer for alcohol use disorder, give you some quick data about immediate intoxication, but a PETH is going to give you data that's not going to be back again just right away before a infusion, but it's that accountability and that potentially could help motivate a patient to maintain some abstinence. More strict monitoring in more high-risk cases, I think, is reasonable, and the monitoring would be paired with medication-assisted treatment and appropriate candidates, as well as chemical dependency counseling or programming interventions. And so the general idea is going to be, does the patient have a ketamine indication or contraindication? And then with evaluating the substance use disorder and whether or not the patient has a substance use mood disorder, thinking about collaborating with the primary psychiatrist, or if there's not a primary psychiatrist, collaborating with the primary care doctor and the chemical dependency treatment team if there is one. One's going to want to come to a conclusion with that team on candidacy, maybe some limitations for continuing ketamine treatment if one is deemed a candidate, and then plugging into alongside the ketamine treatments chemical dependency interventions as needed, and perhaps a monitoring plan. And this may be something in some cases where that doing that treatment or getting active with that and getting some abstinence under one's belt would be done before starting the infusions. I'm going to go through. Okay, this first case here, we've got a patient in her early 60s, history of bipolar 2, as well as concomitant cocaine abuse, and she's had lifelong depression struggles, been through a lot of treatment. Not planning to do ECT at this time due to the cognitive demands at her work. And she seemed like a reasonable candidate for ketamine, but the one issue in her scenario was that she had just stopped cocaine about 2 months ago, so had this comorbid substance use disorder history. More remotely, she was in sustained remission from alcohol, cannabis, and tobacco. Infusion risks in this scenario. Well, if she remains abstinent, then I'd say I don't see any issues. If she did relapse, there's intoxication or withdrawal states that would be plausible during infusions. Is the ketamine going to increase cocaine abuse, alcohol, cannabis? We don't have any evidence for that with the studies that I was mentioning earlier. They're showing a different direction, in fact. Substance-induced mood disorder. I mean, whenever I have a patient with a bipolar disorder history and they're using a lot of cocaine, I wonder about substance-induced phenomena. Here, though, she had continued treatment-resistant bipolar depression, was on a mood stabilizer, and had been abstinent from cocaine for 2 months. I don't think it was the full explanation. It could be a layer. What we did in this scenario is I talked to the outpatient psychiatrist as well as consulted with addiction medicine curbside. And this patient started chemical dependency counseling, and I did a series of comprehensive drug screens. I did weekly in the beginning, and then spaced it out after the patient was in maintenance. The second case, this patient presented in his early 30s. He had major depression, PTSD, but also a very severe personality disorder, very manipulative. Looking at the past psychiatrist notes, the patient wasn't transparent about controlled substances from other clinicians, from ketamine prescriptions from out of state. They were in a lawsuit with some medical facility. The patient, I saw there was messages to their primary care doc demanding prednisone to boost their mood. They had a history of getting online and dark web, anxiolytics, various substances, Russian anxiolytics. And when I evaluated the patient, they were in quite a hurry to get an infusion and demanded that I give them the highest dose possible that we could do. For this patient, then, some concerns here with the infusion risk. So if they've been doing daily powder ketamine, aren't they going to have some tolerance? Also, this isn't a direct to the infusion risk, but kind of long term, I worry about interstitial cystitis risk for folks that are using daily powder ketamine, and I don't want to contribute to that with IV infusions. Addiction risks, I thought it was possible here this patient did have a ketamine abuse disorder, and clearly they had some problems with a polysubstance approach to illicit substances. Substance-induced mood disorder. In this scenario, I don't have all the data listed out here, but I did think this patient had a complex substance-induced mood disorder combined with a severe personality disorder. And the approach in this setting, I told the patient he wasn't a candidate. He wasn't very happy about that. I listed out the reasons why, very frankly and clear to him to make it fair. And I recommended chemical dependency intervention. I talked about that with his outpatient psychiatrist. He decided not to continue with that psychiatrist, and he also decided not to pursue the chemical dependency interventions. So this next patient I've been working with for over a year. He's in his late 20s, an attorney, major depression, PTSD, and I was working with him for his depression treatment in the past, and we got a partial response, but increased functionality. He was able to return back to work, and then at some point after many months of treatment, he decided that he wanted to try off ketamine for financial reasons, and I didn't see him for about 6 months. Well, he did end up going back into major depression. He did lose his job, and it turned out that he, in that setting, started using more frequent cannabis, and I reevaluated him and mentioned that he was going to have to do another urine drug screen prior to starting his infusions. And he mentioned, well, I did use cocaine at this weekend at a social event. And so I talked to him a little bit about that. He said it's very infrequent, but he has on occasion used cocaine at a social event. So looking at his candidacy, what are the infusion risks? Well, increased cannabis use, I'm not sure if that impacts the efficacy or not. There is some GABAergic mechanism of action with cannabis. However, this has not been studied. I'm not sure. Cocaine, if he's using it on some social event, several days prior or weeks prior, I don't think it's going to impact the efficacy or the safety of the infusion. Addiction risk with the studies that I noted earlier, cannabis and cocaine, it's not clear that it exacerbates addiction with those disorders. Substance-induced mood disorder, I wasn't convinced that was a major player here. He was starting to use cannabis more regularly now, but his depression looked fairly similar to prior to him getting more involved with cannabis. Here, I gave him education on this theoretical consideration that, hey, it could be that cannabis is going to decrease the depression, antidepressant efficacy of ketamine. I recommended that he try and de-escalate that, both for his mood in general as well as the ketamine efficacy. I talked with his outpatient psychiatrist, and we actually got him into individual chemical dependency counseling, got him back in his partial response on ketamine for depression. So those are some case examples. Thank you for your attention in the session.
Hello and welcome to the next part of our virtual talk, Pitfalls of Broadening Access, Ketamine at the Intersection of Innovation and Risk. I'm Jeff Zabinski, Director of the Interventional Psychiatry Service here at Columbia, where we have, importantly for this talk, IV ketamine and intranasal S-ketamine. We also have ECT and TMS, and I think it's an important place to think about the role of innovation and access to care. I'm going to be focusing a little bit more on the systems perspectives, as well as some ethical tensions that we feel across the landscape in ketamine right now, in particular linking to the great substance use disorder talk that we've heard so far. So I have nothing to disclose for this talk today. And now just to highlight a few points to kind of get us started. Ketamine clinics and telehealth prescribing have seen a rapid expansion over the last 10 years. You get these ads for all kinds of different companies. Do a quick questionnaire and qualify today. We'll send the oral ketamine to your house. This is possible because of off-label use through compounding pharmacies. You can also get compounded intranasal, subcutaneous, intramuscular. Really, there's an enormous breadth of formulations that are available and that can be available just through a simple prescription. There are growing reports of unregulated self-directed use. This is recreational use, of course, but also misuse from the different companies that are sending, for example, the ketamine to your home. Many patients are not using that as prescribed, and how can we make sure that the regulatory oversight and safety infrastructure catches up with where things are in practice? Currently, it really lags behind. This is a problem that's been pretty clearly recognized by the FDA and by others, and so something that we can talk about in a little bit more detail, because I think it's very important. So to characterize sort of what this looks like over time, and really to get us into the sense of, how many clinics are there, how many patients is this including, I like these two figures from the trends in ketamine and S-ketamine dispensing and administration. So there's a report that was prepared for the Drug Enforcement Agency, the DEA. Figure 1 I chose just to show you that there was an existing base of ketamine treatment for psychiatric conditions that was continuing on, through 2018 to 2020 at, this is a number of patients in thousands. So let's say, in the 50 to 100 range. Then you see S-ketamine get approved, and this is right around the time of 2019, 2020, pandemic time. A lot more attention is coming to ketamine, S-ketamine then you just see both of them together take off. With larger and larger patient volumes over time, with S-ketamine in particular, and then a drop for ketamine in the last couple of years. Then the second figure that I chose is really the percent of patients who have been administered ketamine to S-ketamine in an office-based setting by comorbidity. The idea here is I wanted to especially highlight substance use. I think it's interesting that substance use as a comorbidity is higher amongst IV ketamine, which is the one that's used off-label, compared to S-ketamine. But in both cases, we're looking at 10 to 20% of patients have a comorbid substance use documented. As far as the spectrum of that ketamine, S-ketamine use, thinking about those patients, this is the framework that I usually like to think in. Recreational, off-label, FDA approved. In the recreational space, unregulated illicit without therapeutic intent, this is something meant for recreation. The off-label use, this is the ketamine that you see from compounding pharmacies where there's a therapeutic intent. The patient wants to get better from something, they want some improvement, but it's for ease of access, for cost, for a number of different considerations. including some really snazzy marketing, they may have elected to go with off-label home use as opposed to an office-based treatment, which can be very time-consuming and very pricey depending on insurance coverage. The FDA-approved option in this case really is just the intranasal S-ketamine, Spravato. It's regulated as a risk evaluation and mitigation strategy REMS system that requires reporting for every treatment. There's forms that you fill out, and your treatment setting needs to be registered. The patient is registered and the pharmacies are registered. So really a much tighter control on that product, which is interesting given that it's a set dose and the risk is perhaps lower than the off-label use of IV ketamine and ketamine in other formulations, sort of in that middle box. The FDA started to get concerned about this and said, there are some potential risks associated with compounded ketamine products, including the oral formulations specifically called out for the treatment of psychiatric disorders. And this is kind of marketing gone wild. You have likely also seen these, but I liked this image from the New York Times article talking about ketamine for depression and some of these ads. This is not FDA approved. And so in their statement that they put out in 2023, they really highlight the potential and not clearly defined risks of substance use disorders, misuse, and the lack of proven efficacy from a regulatory standpoint. That doesn't mean that it doesn't work. It may even work better, but it just means that from a sort of regulation standpoint, you're sort of in the off-label sort of wilderness, so to speak. Although, that being said, most of the medication treatments that you're hearing about across the conference really are, in fact, often used off-label. And so thinking about that carefully, I think it's a little bit of a reflection on how much we use medications off-label as well, and being really mindful in our day-to-day practice about how we're using these responsibly. The off-label use, I just wanted to highlight some of these. I took a couple, screen clips from different websites. Learn why 81% of clients prefer injectables. Not injectables in an office-based setting. Subcutaneous ketamine treatment at home, delivered to your home, through the mail. I like to get started by taking our short quiz and schedule a virtual call. Recover from burnout and achieve mental wellness. So now we're outside of the range of diagnosis. We're saying in-home ketamine can help recover from burnout and achieving mental wellness. I think that's sort of remarkable in its how brazen it is for the marketing. And then, just highlighting that ketamine isn't just for depression. In this other box, ketamine, they're highlighting it, ketamine as a proven effective treatment for addiction, which I think, we have learned through the course, hopefully, of some of these talks that maybe it's a little bit more of a complicated picture than just using ketamine for treatment of a substance use disorder. But this is something that patients and physicians, but a lot of patients are asking. I do many evaluations where patients will say, well, can I get addicted to this? How long am I supposed to stay on it? If I'm staying on this for long term, then isn't that kind of, I'm developing tolerance, I'm becoming reliant on this medication and kind of feels like an addiction to me. They'll say things like, well, ketamine treatment made me relapse for those who are in recovery. I have a patient who is receiving intranasal S-ketamine treatment right now who has been in recovery for 40 years from alcohol use disorder. And that patient was really concerned, what will happen if I'm getting this treatment? The end result for that patient is they got better. But, and didn't feel cravings related to alcohol as part of it. Although the patient also commented this aspects of this sensation, the dissociation, remind me of when I used to use. So, it's an important thing to be aware of in that risk. And then how do we know this isn't like when pharma said opiates would be safe. I had this from a patient just the other day saying, isn't there a lot of money to be made, and aren't people being a little more cavalier with this as a result of all that money? And I thought, yeah, good point. And we need to be really thoughtful stewards of treatment and make sure that we are acting in the best interest of the patients and not in the best interest of the bottom line. Another thing that when patients are asking questions like that, one place they'll go for answers is online. I just took a look for fun and I thought I would share with all of you. On Reddit alone, there are forums for ketamine, therapeutic ketamine, ketamine therapy, and ketamine addiction. And it ranges all the way from, I pulled some headlines essentially from last month or so that were the top posts. But from ketamine, why K is the best drug, all the way down to, in ketamine addiction, stop while you can, and highlighting ketamine anonymous meetings. So I think that this is just, there's a lot of stuff out there that people are reading, and they're coming to us for guidance, for our wisdom, and advice that's more medically sound than the Reddit forums. Ketamine and substance use disorder, just to kind of stop on this for a minute. We know that substance use disorder comorbidity is common among patients with major depressive disorder, up to 20%, and there are a lot of different figures from many papers over time. But there was a recent one as far as landscape of ketamine use disorder and looking at outcomes and current treatment pathways. These are both recent publications that I pulled some information from. So up to 20%. There are emerging case reports, ketamine use disorder, even medical settings, meaning ketamine use disorder among patients who are getting ketamine prescribed instead of just acquiring outside of a sort of regulated market. And then these, just acknowledging this dual process tension, they're getting relief from depression potentially, but reinforcement at the same time. I think it just is a call for clinical vigilance, monitoring craving, frequency, escalation, dissociation seeking. This is good to add on if you happen to be treating a patient who's getting ketamine treatment either off-label or as intranasalized ketamine. And just further to perhaps ask if there's a higher degree of suspicion when you're doing your substance use disorder screening, and then coordinating with addiction specialists when needed. I put this, these numbers in here, and you can read those. I want to highlight the first one, that 55% of Americans who tried at-home ketamine therapy reported either accidentally or purposefully using more than recommended dose. And so you can imagine a patient who's not getting relief saying, well, what if I take a little bit more? What if I take a little bit more? And then that may go somewhere. So just from a behavioral perspective, keeping this kind of thing in mind. That's a pretty high number. That's the majority of people who have tried at-home ketamine therapy. I just wanted to highlight, many people have been paying a lot of attention to ketamine in as much as it may be a model for what the rollout of some psychedelics might look like if they're approved. So, MDMA-assisted psychotherapy for PTSD was not approved by the FDA, but is still moving towards approval, thinking through, another phase 3 trial or something like that. I think they have a few different pathways forward potentially. And then Compass with their psilocybin product that is perhaps going to be before the FDA within the next year. So there was a paper that I wrote with a student in the AMA Journal of Ethics, thinking about expanding access while keeping an environment of safety. And I just pulled our quote here because I like it. An unregulated market allows opportunistic practitioners to prey on those seeking treatment or wellness at any cost. So you have these patients who really want to get better. They've tried everything and they're willing to pay huge amounts of money to get it. And I think that puts them in a very vulnerable place. It puts physicians in a very vulnerable place as well. Thinking that, gosh, well, my clinic can be open longer or strengthened or expanded, or I can take another vacation if only I treat more patients with this expensive treatment. And I think that those profit motives can sometimes be put us at risk of making decisions that might not be as ethically sound. On the other side of things, if we over-medicalize, if we overdo it, then are we gatekeeping access? Are we preventing patients who might be getting a safe and effective treatment from receiving that if we put more limitations on this? If we heed the warnings of the FDA and say, we really shouldn't be treating patients off-label. Here we have publications like the one that I've highlighted, At-Home Sublingual Ketamine, Safe and Effective for Moderate to Severe Anxiety and Depression, a large prospective open-label effectiveness trial. I think, what thresholds do we need to use to limit access? And when do we revisit things like rescheduling and so forth? If we broaden access for innovation, how do we preserve safeguards, essentially? So this is just kind of putting together some of these ethical tensions, balancing protection versus autonomy, avoiding exploitation over commercialization, the risk of hypermedicalization versus a sort of self-treatment. Thinking back to that line from the website that said it was for burnout and wellness, basically. So we need to make sure that it's not just another vitamin, conceptualized in that way, that somebody is taking with their vitamin D as it's a low risk supplement or something. And then thinking about our role seriously in as far as transparency, harm reduction, and responsible stewardship. So this intersection of innovation, access, and safety. And then just a final note for the clinic, thinking about some of the abstinence symptoms that you might see if a patient is admitted to the hospital and you're consulted and they have a history of ketamine use, thinking about the potential for ketamine use disorder. So anxiety and low mood and cravings for ketamine being in the majority of cases, also with a high rate of irritability. Most patients are not seeking treatment for ketamine use disorder. And of those who did seek treatment, very few were satisfied with the level of care, not really tailored programs for ketamine use disorder as it stands. So just something that we need to think more about as a field together, making sure that we're getting patients safe and high quality care. And with that, I'll finish up. Thanks so much for joining us, and hope that everyone has a great conference. And please reach out to me or anyone from our talk today if you'd like to discuss a little bit more about ketamine treatment, and hopefully that we all together can make sure that this field grows in the right directions. Thanks so much.